Hello and welcome to DocWire News. MedXChange live program presents this treatment review of relapsing multiple sclerosis. I'm Dr. Florian Thomas. I'm the founding chair and professor in the Department of Neurology at Hackensack Meridian School of Medicine and at Hackensack University Medical Center.
And my name is Dr. Balashov. I am a professor of neurology at Rutgers Robert Wood Johnson Medical School and attending neurology at Robert Wood Johnson University Hospital in New Brunswick.
Dr. Balashov, what does the evidence say about using stronger multiple sclerosis treatments sooner, and why isn't highly efficacious treatment started earlier?
Yeah, so we are limited in our knowledge about long-term clinical efficacy of medications available. Most clinical trials conducted by pharmaceutical company, due to their very high cost, were limited to 2 or 3 years. So if we are talking about a more extended period of time, let's say 5 or 10 years, the data we can rely on basically coming from databases. And there are 2 great databases we have. One is called MS Base. It's about 55,000 patients, which are part of this registry collected mostly in Europe. And then in North America, we have so-called NARCAM database registry. And there we have 35,000 patients. So these patients are entered in this database, and then their follow-up, including clinical disease activity and progression, is entered as well. So based on follow-up of these patients as a part of database, we can make a conclusion what medications are doing better, what are less. Having said that, this is kind of retrospective study. It's observational study. It doesn't include so-called randomization, so there is a bias who is going to be treated with this medication, who is going to be treated with another medication. But nevertheless, if we follow these patients for a long time, we can have approximate understanding what medication is effective and what medication is less effective than others.
Thank you for clarifying your thoughts on the evidence supporting different forms of treatment for multiple sclerosis. So in your clinical practice, how do you utilize prognostic indicators to determine whether escalation therapy or highly effective therapy should be used?
Yeah, it's a very interesting and important question. Unfortunately, at this time, we don't have clear answer. We have only knowledge about prognostic markers. For example, if somebody has frequent relapses or many active lesions on brain MRI, it's more likely that this person will continue to have high disease activity. And probably you want to have powerful medication to stop this activity. So for these patients with, again, frequent lesions we see on MRI, frequent relapses, probably we prefer to use a little bit more effective medication, which we know will decrease relapse rate more significantly compared to low efficacy medication.
Thank you for clarifying that. To what extent do other factors such as gender, ethnicity, location of an MS lesion help you figure out what is the best early treatment?
Thank you very much, Dr. Thomas, for these very important questions. Basically, what we know now that having MS earlier during your lifespan and being a female is a good prognostic marker, while being a male and being diagnosed at age 40, 45 has a not so great prognosis. Then if we are talking about the lesion locations, then of course if somebody has lesion in the spinal cord where multiple fibers, multiple connections are running together, connecting brain and end organs such as muscles and sensory organs, then the risk of these patients to become disabled is much higher compared to patients who have the same size lesions in the brain. So there are many other factors which are having high prognostic value. For example, at the latest meeting ECTRIMS in Norway, I need to correct Sweden, what was found that patients who have atrophy in the cervical spinal cord are more prone to progress to disability compared to those who don't.
Thank you. So would it be fair for me to conclude that you find imaging of the spinal cord to be just as important and informative as imaging of the brain?
So we have, absolutely. So we have two actually things to discuss. If you want to assess disease activity, then brain MRI are probably more valuable because it will show 10 times more lesions, new lesions, compared to number of new lesions in the spinal cord. But if we are talking about long-term prognosis and correlation with disability, then spinal cord probably has a higher impact value, because if we have lesions in the spinal cord or spinal cord atrophy, this will correlate kind of at high degree with disability progression compared to the same measures in the brain. Now, Dr. Thomas, if I may ask, how do you feel about the long-term impact of delaying high-efficacy MS treatment?
So that is a complex question because patients ultimately are the people who decide what kind of treatment they're comfortable with. And many factors go into a patient's decision. Some patients worry more about the effect of treatment, and some patients worry more about the effect of the disease on their long-term prognosis. Factors that will impact patients' decision are, for instance, plans for having a child. And a person's experience with a recent relapse may change their approach to embracing more efficacious treatments. Overall, there are several issues that need to be considered. Quite often, our neurological exam that we typically conduct in our offices is not sufficient to reveal to us the extent of progression, the extent of involvement of neurological function. Some measures that allow us to get a better handle on that include, for instance, neuropsychological testing, which may reveal that a person's ability to think on their feet, to multitask, to plan, to be quick in decision making, has suffered. Another way that we try to quantitate a person's disease state is to measure their walking speed. So if one takes all of these factors into consideration, I think we've realized over the last 10, 15 years that multiple sclerosis is a progressive illness where a lot of the disease activity happens underneath the surface. Some people use the tip of the iceberg analogy to characterize that. So my concern with delaying highly effective treatment is that there may be a lot going on under the surface, some of which one can detect by MRI. An MRI may show a relapse that has not had any obvious clinical consequences, and it is such factors, whether it's MRI or a subtle progression as documented by walking speed or neurocognitive testing, that will impact how I feel about starting more effective treatment.
Now, Dr. Thomas, I would like to ask you about benign MS. So there is this very interesting group of patients with multiple sclerosis who continue to stay with minimum or no disability at all. Is there any way to predict who is going to have benign MS in the future? Will it affect your treatment option?
Thank you. That discussion often comes up with patients who tell me that they have not had a relapse in a number of years. The problem is that it's very difficult to predict who will be in that group, number one. And number two, the definition of benign MS is somewhat difficult to operationalize because, as I hinted at before, there is so much that happens underneath the surface that a patient may not necessarily be aware of. The second aspect to this is that even minimal progression over 40 or 50 years of a person's lifetime can have a significant impact. And as people with MS get into their 60s and 70s and 80s, having a minimal imbalance, that situation is going to be compounded by the effects of aging and the effects of coexisting conditions. So any problem with imbalance or with cognition is going to take on quite a bit of significance. And if I can prevent that through using highly effective medications, I think it's going to be good for the patient. Furthermore, as suggested by a review of the NARCOMS database, at 15 years after the diagnosis, only about 13% of patients have no or minimal symptoms. So for all that reasons, the concept of benign MS is, in my mind, difficult to apply to patients prospectively as we make treatment decisions.
Thank you, Dr. Thomas.
Dr. Balashov, can you tell me how you think about whether high efficacy treatments are in a better position to delay disease progression than lower efficacy treatments?
Yeah, thank you, Dr. Thomas, for this question. Actually, this is something that is developing very fast, this area of studies on high efficacy versus so-called escalation therapy, when low efficacy treatment is started first and then maybe high efficacy is taken place. So the best probably evidence or publication devoted to this question came in 2018 and was published at JAMA Neurology. The study is based on analysis of more than 1,500 patients who are part of so-called MS-based, a big registry data of patients with MS, mostly of European descent. And what the study shows that patients who were initially started on high efficacy drug, at that time it was Lemtrada, Tysabri, and Gilenya, were doing better in a long term compared to patients who were started on low efficacy drugs such as interferon beta based medications and Copaxone. So the study compared how fast patients included in the study developed increased disability. So having said that, there are certain limitations in this study. For example, this study was not randomized, and it may have bias in selecting patients to be started on this or another treatment. Another interesting point of this study was that if patient who was started on low efficacy treatment such as Copaxone or interferon beta and then was switched to high efficacy treatment, they were doing better compared to those who continue to stay on low efficacy treatment.
Thank you very much.
So, Dr. Thomas, I would like to ask you, what do you think is the right time to give a patient a high efficacy treatment?
Thank you. It's a difficult question to address for a given patient. I am of the opinion, based on the discussion you and I have just had, that it is in the patient's interest, in most patients' interest, to start high efficacy treatment relatively early if all the patient's circumstances are conducive to that, such as plans for pregnancy, for instance. But I think it's important to realize that many different factors go into a patient's decision what kind of recommendation to accept at a given point in time. And it is important to have ongoing discussions with patients that reflect an integration of the patient's history, the patient's change in physical examination, a change in MRI appearance, as well as what a patient's life situation is like at a given point in time. and to reassess in an ongoing fashion what is the best treatment course for a patient right there and then. I'm thinking about a conversation that I was part of in which a patient shared with a patient support group that a couple of years ago, and with a single relapse in his history, this gentleman had told his physician that in view of the fact that he was raising 3 children, he wanted to have as much comfort as possible that he would be relatively protected from a relapse and disease progression going forward. And he therefore told his physician that he wanted to be treated with alemtuzumab at a very early stage in his disease. He shared with us that he did very well on that treatment, and that retrospectively he was very glad to have made that decision.
Oh, interesting. Thank you very much for bringing this example.
So the bottom line is it is important to take every patient as an individual who may have specific circumstances, both based on the history of their MS and as well as other life circumstances that may determine what is the best treatment course for that patient at a given point in time. Dr. Balashov, you illustrated the evidence based on observational studies in terms of comparing high efficacy and lower efficacy drugs. However, for the drugs that have received FDA approval, obviously in many instances we do have results from prospective blinded studies as to how high efficacy drugs do compared to other drugs in terms of prevention of disease progression and relapses. Can you summarize what these studies showed?
Yeah, it's my pleasure to do it. So why do we have these names? Low efficacy, high efficacy. Basically, it's coming from prospective clinical trials. For example, drug A was tested in patients with relapsing remitting MS and compared to placebo. And then at the end of study, we can say, okay, this drug was more effective in reducing relapse rate or number of relapses the patient experiences during this period of time, and number of new lesions, which we can detect using MRI. And based on this study, we can divide drugs into low efficacy, like intermediate efficacy, and high efficacy. So what are low efficacy drugs? These are basically drugs we have been working with for 20 years. For example, first drug called beta-seron, based on interferon beta, was introduced in 1993. Then we had Copaxone, generic name glatiramer acetate. So these drugs, if given to patients with relapsing remitting MS, will decrease relapse rate by approximately 30% compared to placebo. And they will decrease number of new lesions on brain MRI by approximately 50%. Then we have a group of drugs which are mostly oral drugs, and we have these drugs for about 10 years, such as brand name Gilenya, Tecfidera. These drugs are popular because they are convenient naturally, and they also have reasonable efficacy. They decrease relapse rate by approximately 48–52% compared to placebo, and then they decrease number of new lesions we see on MRI by approximately 70%. And then we have a group of high efficacy drugs. So these drugs are mostly antibodies, monoclonal antibodies, targeting specific subsets of cells. So these drugs are decreasing relapse rate. The data with these medications are limited mostly to comparison study with other drugs, but at least one was tested against placebo and called Tysabri, and it reduced the relapse rate by 68% compared to placebo and decreased number of active new lesions by approximately 90%. So these high efficacy drug, we are talking Lemtrada, Tysabri, acrylzumab. So these drugs are all monoclonal antibodies. They are very effective, but there is another side. Of course, if drug is more effective, you expect that there is a high risk of serious adverse effects, which we need to discuss with patients.
Thank you. That was very illustrative. So we are really on pretty solid ground in considering the benefits of highly effective treatment.
Yeah, that's correct. And so for these drugs, it's mostly about decreasing disease activity, which, as I mentioned, defined by decreasing relapse rate and number of new lesions we see on MRI. But the second part, which we are becoming more and more interested, is what is a long-term prognosis? And we shortly discussed it before. So we are waiting for more results to come. And our, of course, internal feeling that most likely that high efficacy drug will be better than low efficacy drug in decreasing long-term disability. But this is something we have to see results.
Now, you talked about relapse rate and MRI lesion load, but I believe the same benefits hold true for disease progression.
Yes, for these drugs, disease progression is unfortunately limited for clinical trials to approximately 2 years.
Sure.
And most of these drugs were effective in decreasing disease progression. However, numbers were not so striking compared to decreasing disease activity and number of new lesions. We are talking about numbers approximately between 20 and 40% decreasing disability progression. So this is a little bit more difficult topic, and numbers are not so exciting. So Dr. Thomas, we have actually a wonderful time now. We didn't have any medications prior to 93 for MS. Now we have 10 different mechanisms and about 16 different drugs available. So what impact are advances in therapy having on the way patients are treated in your clinic?
We are slowly moving towards what is sometimes referred to as precision medicine, which refers to the ability to customize a person's treatment based on specific characteristics of that patient. At the current stage, this is largely limited, however, to a customization based on our tentative determination of a person's prognosis, as well as a consideration of a person's comorbidities, such as diabetes or heart disease, or any kind of underlying infections. We would like to be able to utilize any evidence from genetic tests that may help us predict who will respond best to a given medication. This is an area of intense study, and I'm going to very much look forward to finding out what these studies show to allow us to accomplish that. At this point, we are not quite there yet, however.
Now, Dr. Thomas, I would like to ask you the following question. So when you have a patient coming to your clinic, how do you decide what medication to choose from many options available? Do you involve patient in this treatment decision process? Do you think that it will impact patient's compliance, for example, or success of treatment?
Absolutely, and I think that's a very important point to consider. We know, for instance, from some of the interferon utilization studies that many patients stop taking these medications after 2 to 3 years. And of course, as our former Surgeon General said, medications don't work in people who don't take them. C. Everett Koop, Surgeon General in the 1980s. So it's really important to make sure that patients are on board, and it's really important to inquire with patients in a non-judgmental fashion whether they're taking their medications. because medication adherence is a big issue, whether we talk about disease-modifying drugs in MS or whether we're talking about symptomatic treatment for MS symptoms and signs. So patients need to be on board, and it's important to reflect in conversations with patients both one's own thoughts about the risks and benefits of medications, and ask the patient to share their thoughts on the same topic. So Dr. Balashov, we've talked a lot about MS as a clinical condition. We've talked about how to think about different treatment options. But of course, we've also learned a lot over the last 20 years as to disease mechanisms in multiple sclerosis. Can you tell us a little bit about how your understanding of MS as a disease has evolved?
Yeah, thank you, Dr. Thomas, for this question. This is a fascinating story. I happened to have training in neuroimmunology and have a PhD in immunology, and spent a number of years working in the lab. So 30 years ago, 20 years ago, we thought about MS as so-called autoimmune disease mediated by T cells. Then we became unhappy because there was no clear-cut antigen, and so we don't call it autoimmune disease any longer. We call it immune-mediated disease. Why? Because the immune system is critical in MS, and if you suppress the immune system, disease activity will be suppressed as well. So what happened in 2008? The paper was published in New England Journal of Medicine based on a small study, approximately 100 patients with relapsing remitting MS, and they were treated with medication, if I'm not wrong, called rituximab. But the key point is that this medication was targeting B cells. And to everybody's surprise, this medication was very effective. And relapse rate was decreased by more than 50% in patients treated compared to placebo. And from 2008, we have a new era in understanding of MS. Now we call MS is B-cell mediated disease, or at least B cells have a very critical part in MS pathogenesis. And a number of medications have been introduced targeting B cells, and they show very good efficacy. So right now, again, we are in the stage when immune cells, especially B cells, are very important for MS. Also, I need to mention that there are two pathogenic mechanisms in multiple sclerosis. First is neuroinflammation, and mostly it depends on cells of the immune cells, such as immune system, such as B cells, macrophages, and so on. And then there is neurodegeneration, which is another part of MS pathogenesis. So early on, when MS starts, it's mostly neuroinflammation which is driving disease activity, which, by the way, and nobody understands why, subsides over time, even without treatment. But as time goes on, neurodegeneration is picking up, and connection between neurons do suffer and intersected. And there is brain atrophy and spinal cord atrophy we witness in our patients with MS, and this correlate with the disability. So this is a very challenging area and a very unmet need area. Hopefully, we will have new medications in the future to address this topic.
Thank you. You just covered, in a very short period of time, a lot of territory. So if I may just ask some follow-up questions on that. As you and I know very well, we obviously had hints as to the relevance of B lymphocytes in the pathogenesis, because for 30, 40 years we've determined the presence of oligoclonal bands in the spinal fluid. And obviously the immune system is really complex with multiple crosstalks between B lymphocytes, T lymphocytes, and other T regulatory cells. How do you understand the effect proceeds when one decreases B lymphocytes through medications such as ocrelizumab to also modulate the activity of T lymphocytes?
So again, in the past, we looked at B cells and thought, okay, these cells are very important because they're being transformed to so-called plasma cells producing antibodies. And antibodies will fight viral cells, bacterial cells, protect us from infection. After that finding that B cells are so crucial for multiple sclerosis, this topic was revised, and a new knowledge emerged that B cells are not only cells which are becoming plasma cells, antibody-producing cells, they're also important for T cells to get activated, so we call it antigen-presenting cells. That's one point. Second point, B cells are also producing many cytokines which are driving T cell responses. For example, B cells produce cytokine called interleukin-6, and interleukin-6 is promoting generation of so-called Th17, T cells producing interleukin-17, which is considered to be one of pathogenetic mechanisms in multiple sclerosis. So now B cells have at least 3 different functions, which we believe strongly important for MS. Again, presentation, antigen presentation to T cells, cytokine production, and then the old function, which we are well aware of, being transformed to plasma cells and producing antibodies.
Thank you. And of course, then we have drugs such as cladribine or alemtuzumab, which have a more comprehensive effect on the immune system, at least on the surface. How would you characterize how such drugs are beneficial in multiple sclerosis?
Those drugs were found to be also effective in patients with multiple sclerosis, at least in patients with relapsing remitting MS. For example, alemtuzumab, it's targeting molecule called CD52 on the surface of not only T lymphocytes, but also B lymphocytes and other cells. So it's less specific compared to, let's say, acrelizumab or rituximab. But it's very effective. So then we have cladribine. This drug is working at the level of nucleic acid, and it's also effective. We know that nucleic acid metabolism is important, especially in cells which do proliferate very fast, including cells of the immune system. However, this topic is more complicated than, let's say, medications which are based on monoclonal antibodies, which have a very precise target. So that's what we like about monoclonal antibodies. We know what they're targeting, and we know what to expect.
Thank you. You just looped back to clinical presentation when you specified talking about a medication, at least in relapsing forms of MS. And before you had talked about how there is an inflammatory component to MS as well as a degenerative component to MS. How in your practice do you deal with patients who have entered the secondary progressive phase of MS, who have been on a monoclonal antibody, for instance, and who continue to progress, where you have ascertained by MRI that there are no non-clinical relapses? That is obviously a big challenge in our clinical decision making. What do we do with such patients? Would you like to comment on that?
Yeah, that's a very interesting topic. So patients who are in late stage of MS, called secondary progressive MS, can be divided into 2 groups. One group is those patients who continue to have relapses. And for those patients, we basically continue to use the same medications we prescribe to patients with relapsing remitting MS. But then we have a patient with secondary progressive MS and with no relapses. And this is a big challenge because basically we don't know what medication is going to work. So now we would like to discuss benefits that patients with multiple sclerosis are going to have from high efficacy treatments. What's your opinion, Dr. Thomas?
Thank you. Well, You had already discussed prognostic indicators of patients who a priori should be considered for high efficacy drugs. And I had discussed that in the content of benign MS, that in my mind, the majority of patients are better off being on high efficacy drugs. So I think in my clinical practice, I integrate those 2 points of view. If there are specific factors, such as what you hinted at, gender, recent number of relapses, MRI activity, location of lesions in the brain versus the spinal cord, I take those factors into consideration. I take a patient's life perspective into consideration, both in their professional and personal lives. And very importantly, I take into consideration how a patient considers the risk of disease versus the risk of the treatment. And then I try to integrate that in my conversations with patients, and with the goal of reaching a consensus. And my general approach to that is to start a more effective drugs earlier in the treatment course. In the treatment course. Thank you.
Thank you, Dr. Thomas.
How do you do that?
So we usually have a discussion with the patient, and I'm trying to figure out what's the priority of this particular patient. Is it safety? Is it convenient? Is it efficacy? And I try to explain that there are different drugs and they have differences. In general, drugs which have high efficacy, you need to be more careful with these drugs because they can also cause high risk of serious adverse effects. And based on this discussion, I try to prescribe a drug, I hope, will be able to control patient's disease, and then I will follow this patient, and if I see that the drug is not working enough, not able to control disease activities, then I will upgrade this patient to a more powerful medication, which is less safe. This is called escalation therapy. But after looking at these publications in 2018-19 about long-term effect of high efficacy drug, I'm rethinking this issue and looking forward to learning more about prospective studies which are conducted now about starting high efficacy drug at the beginning. So we probably move to that area if results of these clinical trials are positive in approximately 4 or 5 years. It's my rough estimate. Because basically you really need to have a good balance of efficacy and safety, meaning a ratio of clinical effects towards potential risks. And so this is a rapidly evolving area, and it's exciting time, and looking forward to new information which I'm going to receive in the next several years.
Could you summarize for us the prognostic indicators that you find best evidenced in the literature and most useful in individual patients to help you start a discussion about optimal treatment for a given patient?
Yeah, so we discussed briefly, there are certain prognostic markers we use in our assessment of making predictions. So for example, being male, age 40, having first symptoms of MS is generally not the best prognostic marker. It's better to compared to female who is at age 20 who would have a better long-term prognosis statistically in a group. Then also patients who have frequent relapses or multiple lesions on brain MRI in the first 5 years, those patients are going to do worse compared to patients who have rare relapses and low number of active lesions on brain MRI. So these are markers of disease activity. Then we are talking about disease progression, meaning patients gaining disability, permanent disability. And this is a very critical, important topic we are paying more and more attention to. For example, what's the chance for the patients to become cane-dependent or wheelchair-bound? It's not so bad, actually, as we thought before for patients with relapsing remitting MS. Based on recent publications, based on one of these registries I mentioned, NARCOM study, we know these days that for the patient with relapsing remitting MS to become cane-dependent, it would take on average 30 years now for 50% of patients with relapsing remitting MS to become cane-dependent. In the era when no medications were available, that number was 20. So we have a significant progress in the era of medications compared to our time in the past. But then what are markers would correlate with disability progression? These are mostly first atrophy. And the impact of atrophy in the spinal cord, brainstem, thalamus is very important. So we can look at patients' MR images and discuss it with the patient that, okay, based on what you have a high probability of develop sustained disability in the future. But this is a part of the story. We also want to have very effective tool available to address this problem. So this is what hopefully we will have in several years when results of prospective clinical trial with high efficacy drug versus escalation therapy will become available. But even now, for some patients with significant risks to progress, I tend to lean towards high efficacy drug from the beginning. So then somebody can ask, what's the impact of lesions on MRI? Why we do MRI? We can just look at relapses, clinical symptoms. Well, this is a very interesting point. If you do MRI and look at this more often than we do now, let's say once a year, then you will see that number of lesions we see on brain MRI will be 10, 30 times more than the number of clinical attack. It's fascinating. MRI is an extremely sensitive tool which helps us to decide if disease is active and what's the risk of disability progression. So that's why we use MRI these days. For example, if somebody has a lesion in spinal cord, brainstem, optic nerve, then patient is very likely to develop symptoms. But if patient has a lesion in so-called periventricular lesion area in the center of the brain, then it's very likely that patient is not going to feel it and remain asymptomatic. So this is power of MRI. It gives us more information, more prognostic information, and more correlation with disease activity and progression.
Thank you, Dr. Balashov. I thought we had a good discussion today. I certainly learned a lot. I hope our audience learns too. Thank you.
Thank you, Dr. Thomas. It was a great pleasure to be a part of this conversation.
Thank you.